Hello, everyone, and welcome to our question lab. We will be covering oncology this evening. I want to thank all of you guys for joining us and thank our panelists and our presenter and question dissector for joining us as well, Dr. Paras Vakaria. Before we begin, I want to introduce all of our panelists and staff to you. My name is Sean. I've been with RX Coach for a little over a year, working with lots of students to help them achieve their academic goals. And along with me today, we have Dr. Paras Vakaria. Paras.
Thank you, Sean. Hey, everyone. My name is Paras Vakaria. I am a resident physician in dermatology at UT Southwestern in Dallas, Texas. I originally completed pharmacy school in St. Louis, Missouri, and then went back home to Michigan to further complete medical school. I have worked as an RX coach as well as something we'll talk about later today, but I've worked as an RX coach for a little under a year now. Primarily working with students for step one in some of the question answering techniques that we'll kind of go over today as well.
Wonderful, and that's Dr. Vakaria, derm resident there out of Southwestern, and we have one of our other RX coaches with us, one of our top rated RX coaches, Mark Heslin.
Hey guys, my name is Mark Heslin. I'm a third year med student at Cooper Medical School of Rowan University. I'm living in Philadelphia right now. And I've been a Scholar RX coach probably for the last 6 months, and I'm excited to answer all your guys' questions.
Wonderful. Speaking of questions, we do have 2 additional panelists, and if you look at the right side of your control panel for GoToWebinar, you will see a question box. Throughout the webinar today and presentation, we will be asking you to input answers there, but it's also there for you guys to ask us questions. And Mark, along with Jeff Downing and Kate Hoffer, will be happy to try to answer as many of those questions as they can. You guys heard briefly about RX Coach. RX Coach is our new one-on-one tutoring program where we work with students on an individual basis to help them create a study plan, focus on weak areas, bridge knowledge gaps, and finesse their test-taking skills. I see a lot of our RX Coach students here today, so welcome to you guys as well, and thanks for being a part of the program. So the approach we're going to use today is the same approach that we use in RX Coach, and we'll talk about that a little bit later as the presentation continues. Before we move on, now that you've met us, we'd like to get to know you. So I'm going to ask you guys a question. It'll be on your screen, and the question is I picked the wrong one there. Is what exam are you preparing for? So if you guys will take a second and please submit your responses. We'd like to get to know you. These are the same polls that will pop up throughout the webinar today for each question that we do, so you guys can submit your answers and we can see how all of us are doing with these questions. So I'll give you guys a couple more seconds to answer this question, then we'll move on to the next one. All right, looks like about a third of you guys have answered. We'll give you guys another few seconds to submit your responses. All right, looks like about 2/3 of you guys have answered. So let's see who is on the webinar tonight. Looks like about 93% of you guys are studying for step 1. We've got some studying for the CBSA, COMLEX, step 2 CK, as well as for school exams. And the presentation today should be helpful for all of you. Since most of you guys are studying for step 1, let's take a look here. Once again, the approach that we're using today will be the same approach that we use in RX Coach. RX Coach, of course, is our new tutoring program. So you get one-on-one coaching and score higher. So with that being said, and without further ado, we'll go ahead and get into our first question of the evening. As you guys can see, the answer choices are not visible on your screen, and that is by design. The first step that all of our RX coaching students will tell you is that we have you cover up your answer choices or hide them, and you can do this on test day with your scrap paper or with your hand, and while you're practicing at home with the Post-it note. And the reason we like students to do that is because we don't want these answer choices to guide your thinking. We don't want you to be skewed by what you're reading, and we don't want you to see an answer choice that you may be unfamiliar with, and that might cause you to panic during the question. We don't want that to happen. So we're going to cover up those answer choices. As you can see, I've already done that for you. And after we do that, we're going to read the last sentence, more commonly known as the lead-in question, or lead-in sentence together. So here we go. Which of the following is the most likely diagnosis? So on the exam, you're going to have 1-step questions, 2-step questions, and 3-step questions. And after we read the lead-in, we want our students to tell us, is it a 1-step question, a 2-step question, or a 3-step question? And that helps us organize our thoughts and make sure that we're answering the correct question and not forgetting to go that extra step to answer it correctly. So an example of a one-step question could be where they ask you for a diagnosis, which is a question like this. Another example of a one-step question, an example of a two-step question would be when they ask you, what is the treatment for a diagnosis? And an example of a three-step question could be where they ask you, what is the mechanism of action of a treatment for that diagnosis? So one-step question, two-step question, or three-step question. This time I gave you the answer, but going forward, I'll give you guys a second to think about how many steps each question will require. And of course, Dr. Vicaria will go over that as he explains the incorrect and correct answer choices to you. After we read the lead-in, we will read the question stem together. And during our coaching sessions, we'll give you a second to pause and we'll kind of pick your brain. Hey, what are you thinking? What are the clues? What's important? What do you want to highlight? What are you thinking? What's on your list of differentials? Since we don't have time to do that today, because we have so many of you, and I'm glad we do, I will pause briefly after every sentence to give you guys a second to gather your thoughts. So with that being said, let's begin reading the question stem. A 67-year-old former landscaper is referred to the dermatologist for a lesion on his right forearm. The lesion is a flesh-colored, shiny lesion, approximately 1.5 centimeters in diameter. A biopsy is taken, and the results are shown in the image. So I'll give you guys a second to take a look at that image. And of course, we have a derm resident leading today's question dissection, so this is right up his alley. And after we've read the stem and looked at the image, we will read the lead-in one more time. Which of the following is the most likely diagnosis? And with that, I will hand it over to Dr. Vicaria.
Thank you, Sean. So we'll kind of go through all of the answer choices. The first thing we do at this step is we start at the last answer choice and then we work our way up. The reason we do this is we want to make sure that you're looking at all of the answer choices before you select an answer, and you're not becoming distracted by anything that you think is correct and may in fact be incorrect. So in this case, we will start at the bottom and work our way up. So let me go ahead and read those out loud. Answer choice E, seborrheic keratosis. D, melanoma. C, dermatitis herpetiformis. B, basal cell carcinoma. And A, actinic keratosis. So go ahead and gather your thoughts. We'll give everyone a couple seconds to do that. Sean's going to go ahead and open up the poll. Please go ahead and select the answer choice that you think is correct, and we will talk about it in just a couple seconds.
Excellent. Thank you, Dr. Vicaria. So as you guys can see, we have a poll launched for you guys. We'll wait and collect some of these responses. Then we'll review the correct and incorrect answers together. So I see some of you guys have answered. We'll wait on more of you guys to submit your responses. Remember, on test day, there's no incorrect, there's no penalty for guessing. So if you don't know what the answer is, feel free to take your best shot and never leave a question bank on test day or now for that matter. So I'll give you guys a couple more seconds to submit your responses and then we'll review them together. Well, it looks like about 2/3 of you guys have responded. So let's see how you guys did. So it looks like 50% of you guys picked B, basal cell carcinoma, and answer choice A, actinic keratosis, was in second place with 25% of you guys selecting answer choice A. Let's see what the correct answer is. The correct answer is B, basal cell carcinoma. So great job to all of you guys who got it right. If you didn't get it right, that's okay. It's not test day. We're here to learn together, and hopefully you'll know it and get it right when the big day comes around. And with that, I'll hand it back off to Dr. Vicaria.
Thank you, Sean. So here we have a little bit of a small table from first aid that kind of describes a basal cell carcinoma or basal cell cancer. It is actually the most common skin cancer and usually found in sun-exposed areas, okay? The classic saying is a pink pearly nodule or a pink pearly papule. Oftentimes there will be little blood vessels that kind of surround the edges, or what's known as telangiectasias. It can have a nice rolled border and then a little central ulceration, kind of like a very small volcano. The key thing is when you look at it on histology or on pathology, it has this palisaded appearance. And we'll talk about that in just a second. So let's go back to that question. So that they told us this patient presents with a flesh-colored shiny lesion. So shiny is what they're getting to at pearly, okay? It's also pretty big. It's 1.5 centimeters, so about an inch. It's also on his forearm, which, as we know, is a sun-exposed area. So thus the likely diagnosis is a basal cell skin cancer. So what are we looking at in that image? And that's kind of a key clue here as well. If you look at those kind of dark blue purple balls within the dermis, at the very edge, you can see that the nuclei are kind of lining up almost in like a picket fence appearance. They're all kind of grouped and huddled together and almost forming like a little barrier at the edge. That's called peripheral palisading and is pretty characteristic of basal cell carcinomas. You would not see that in actinic keratoses, squamous cells, or melanomas. That's highly specific to basal cell skin cancer. So that's another key clue here that this is a basal cell cancer. So let's go over why it's not any of the other answer choices. E, seborrheic keratosis. This is a benign lesion that's usually pigmented, and the key phrases are waxy or stuck on. So almost something that looks like it was literally just stuck on there and you could peel it off. On histology, you would usually see acanthosis or thickening of the epidermis and what are called horn pseudocysts within the epidermis as well. So this patient's lesion and histology are not characteristic of a seborrheic keratosis, so likely incorrect. D, melanoma. So let's remember our ABCDEs of melanoma. Do you guys remember what those are, the ABCDEs of melanoma? We actually have, if you look at the right side of your screen, we have a question box. If you want to go ahead and open that up, go ahead and post in there what you remember are the ABCDEs of a melanoma lesion. And then we'll kind of talk about that in just a second.
Excellent. So we'll take a look here at those responses. And it looks like we have some pretty good responses and good thoughts coming in. So Dr. Beccaria.
Yeah, thank you, Sean. So classically, the ABCDEs, A stands for asymmetry. So if the lesion is asymmetric, B is border. So if there is an irregular border, it's not a nice, smooth, round border. C is for color. So if there's multiple colors within the lesion. D is for a diameter that's greater than or equal to 6 millimeters, or classically what we like to tell patients is bigger than an eraser on the back of a pencil. And then E. E has kind of changed over time, but for the most part resolves to evolving. So is that lesion evolving or changing over time? And those are all some characteristic features of a melanoma. Now, in this question, they didn't really tell us anything like that. It is 1.5 centimeters, but there's nothing about asymmetry, irregular colors, and there's no picture here that is characteristic of that. On histology, what we would see are more cells that have pigment in it, so more melanocytes. So again, not what we're seeing here. So D is likely an incorrect answer as well. Answer choice C, dermatitis herpetiformis. So this is a skin condition associated with celiac disease, if you remember. And this is characterized by very itchy bumps or papules and vesicles, usually on the elbows, the knees, and the buttocks areas. What you would see on histology classically are clusters of neutrophils that are forming small little abscesses in the papillary dermis. So the level of the dermis that is just below the epidermis, that's a papillary dermis. This patient's histology does not show that, and thus is likely an incorrect answer here as well. We talked about how answer choice B is a correct answer, so let's move on to answer choice A, actinic keratoses. These are pre-malignant lesions that can sometimes convert into squamous cell cancers. They are most classically characterized by small, rough, kind of gritty red papules, and usually you'll see a picture of someone's scalp or the back of someone's hands, and you'll see numerous small, rough, scaly spots. On histology, what you would see are keratinocytes that are very atypical, but they're only atypical at the lower part of the epidermis, and that's why it's just an actinic keratosis or pre-malignant and not a squamous cell, because that would be involving the full thickness layer of the epidermis. This patient's histology nor the signs are consistent with an actinic keratosis, so likely an incorrect answer. So the main takeaway point from this question is that, dermatologic lesions are often troublesome for medical students, especially on step 1. So it's important to review a lot of images to know exactly what they look like clinically, but also histologically, and to keep in mind any important associations or mnemonics that can help you remember them.
Excellent. Thank you, Dr. Beccaria. So once again, this was a one-step question, and you saw some clues that we highlighted for you that hopefully got you to the right answer. So with that being said, a great job to those of you who got it right. For those of you who didn't, we'll get it right on test day and next time. So let's move on now to question 2. Once again, for those of you just joining us, we do have the answer choices covered up, and that is something we do as part of our RX Coach program. And the reason we do that is because we do not want these answer choices to guide or dictate your thought process. And we don't want students to see an answer choice that they're unfamiliar with that might cause them to panic as they're reading the question and throw them off their A game. So I've already covered those answer choices up. After that, we're going to read the last sentence or the lead-in first, and let's do that now together. So, which of the following findings is pathologic examination of biopsy specimen most likely to show? Once we've read the lead-in together, we will read the question stem together. A 58-year-old woman comes to the physician for her first physical examination in 10 years. She states that she has been in good health and has no history of significant illness. The patient denies a history of alcohol or tobacco abuse. On physical examination, a 2-centimeter firm, fixed, and non-tender right axillary lymph node is palpated. A biopsy of the lymph node is performed. Which of the following findings is pathologic examination of biopsy specimen most likely to show? Dr. Beccaria.
Thank you, Sean. So once again, we'll go ahead and start at the bottom and work our way up. Answer choice E, proliferation of intralobular stroma distorting the associated epithelium. D, large germinal centers with numerous mitotic figures and necrotic cells. C, globular myxoma cells. B, clusters of small basophilic epithelial cells. And A, anastomosing sheets of pleomorphic cells that express HER2/NEU or HER2. We'll give everyone a couple seconds to gather your thoughts, and then Sean's going to go ahead and open up that poll. Please go ahead and select the answer choice you think is correct, and we'll talk about it in just a couple seconds.
As you can see, some of the answer choices here have some abbreviations in them. They're a little truncated because we can't put all the characters in there, but hopefully there's enough for you guys to make out what these answer choices are. The L in D stands for large. So large germinal centers is what we're going for there. We'll give you guys a second to respond, then we'll go over the correct and incorrect answers and review what clues in the question would have helped us get to the right answer. We'll give you guys a few more seconds to respond. And it looks like about half of you guys have responded. We'll give you guys another second. Keep in mind that if you guys don't know what the answer is, feel free to take your best guess. There's no points for guessing on the test, and certainly not here tonight. All right, looks like about 2/3 of you guys have answered. Let's see how you guys did. So it looks like 42% of you guys picked A, anastomosing sheets of pleomorphic cells expressing HER2. And in second place was D, large germinal centers with numerous mitotic figures and necrotic cells. So let's see what the correct answer is. The correct answer is A, and it looks like 42% of you guys got it right. So with that, I will turn it back over to Dr. Beccaria.
Thank you, Sean. So this is a patient that presented with a 2-centimeter firm, fixed, and non-tender right axillary lymph node. Now remember, the breast has direct lymph drainage into the axilla. And we're just going to flash back over to that question slide real quick. So the breast has direct lymph drainage into the axilla. So this is a mid-50s or late 50s female who they said hasn't seen her doctor in 10 years. So she probably hasn't had breast exams or mammograms or any other screening exams. So it's very likely that she has breast cancer here. Now, 1/3 of breast cancers present with lymphadenopathy. The most common sites of lymphadenopathy are the axillary sites, internal mammary, and supraclavicular nodes. Now, in breast cancer, do you know what the most common invasive malignant breast cancer is? Once again, go ahead and open up that question box, post your answer, what you think is the most common invasive malignant breast cancer, and we'll talk about it in just a second.
If you guys really want to cheat, I guess you guys can look at my screen because I have the diagram up with the explanation. So looks like we got some good responses. Dr. Viccaria.
Yep, thank you, Sean. So the most common invasive tumor is an invasive ductal carcinoma. It commonly arises in the upper outer quadrant of the breast, as do most breast cancers. It is made up of anastomosing sheets of pleomorphic cells, and the aggressive tumors can express HER2, as is listed there, that there can be overexpression of H2 in various types of breast cancer. In addition, axillary lymph node metastasis is the most important prognostic factor in early stage disease. That's very important to remember. So in this question, answer choice A is a correct answer, but let's talk about why the other answer choices are incorrect. So answer choice E, proliferation of intralobular stroma that distorts the associated epithelium. That is referring to a fibroadenoma. It is a benign breast tumor that is small, firm, rubbery, and mobile. Now the question told us nothing about anything like this, nothing about a small, firm, mobile mass in her breasts on physical exam, just a palpable lymph node. That's all they told us. Furthermore, fibroadenoma of the breast does not metastasize to the axillary lymph nodes. So thus this is likely an incorrect answer. Now let's talk about D. This is the second highest selected answer. So large germinal centers with numerous mitotic figures and necrotic cells. This is a tough one, but this is actually referring to lymphadenitis. So lymphadenitis is due to microbial drainage from an infection in the extremities. So in those cases, you could have enlarged lymph nodes, but they would be swollen and tender. Now in this question, they told us that this was fixed and non-tender lymph node. Furthermore, the patient would also have some signs and symptoms of an infection, which is not the case here. So answer choice D is likely incorrect. Answer choice C, globular myxoma cells. So this is referring to a myxoma. These are rare tumors of the heart that are not commonly known to metastasize. Furthermore, the patient doesn't have any cardiac symptoms from the question sum that they gave to us. So there's nothing there that would really make us concerned for a cardiac myxoma tumor. Answer choice B, clusters of small basophilic epithelial cells. This is referring in this question to a small cell lung cancer. Now this also does not normally metastasize to the axillary lymph nodes. And furthermore, this patient is not presenting with any respiratory symptoms. As Sean had highlighted, the patient has otherwise been in good health and has no history of significant illness. Furthermore, the patient denies any tobacco use. So this constellation kind of points away from any sort of lung cancer. Thus, why answer choice A is the correct answer choice. So a key takeaway, oh, go ahead.
No, go ahead.
Oh, yep, so a key takeaway point from this question is that any firm, non-tender lymph node should always make you suspicious for cancer. And anytime the question gives you clues suggesting that this patient hasn't seen a doctor in years, they're cluing you in that this patient may have something that may normally be caught by routine screening. So keep that in the back of your heads as well.
Well done, Dr. Vicaria. Thank you very much. And you know, you guys did a great job. You guys had 42% of you guys got it right. A lot of you guys, you know, for some reason didn't get it right, but that's okay. This is a learning process. And these question dissections are really helpful for a lot of students, and we encourage you to join us every Tuesday evening. Next week, the subject will be immunology. So same place, same time, next week, immunology. So before we continue, I want to tell you guys a little bit about RX Coach, and make sure you guys stay till the very end because 2 lucky winners are going to win a raffle, and we have a special offer for all of you guys as well, but you must be present to win. So like I said, RX Coach is our new individual tutoring program. This is ideal for people who want to maximize potential on test day. A lot of students, they end up studying, but they don't see the results they want, and that's oftentimes because they maybe aren't focusing on the right area at the right time or studying in the right order, or they're unable to diagnose their strengths or weaknesses and unable, therefore, to master test taking and finesse those test taking skills. So we work on all those things together. We work on knowledge, we work on content, we work on test taking skills, and closer to testing, we work on timing and stamina. We begin with a 160 question assessment so that we can help you develop a personalized study plan. It is a one-on-one approach, and we have highly trained RX certified tutors who've been very carefully selected and thoroughly trained, and you met Dr. Vicaria today and Mark Heston, one of our other coaches. We also give you access to RX 360 and RX Bricks as a part of every single tutoring and coaching package that we offer. So if you are interested in talking more about tutoring and learning more about our tutoring program and how it can benefit you, you can visit www.rx-coach.com to schedule a free consultation. And once again, that consultation is to discuss our tutoring program and how it can benefit you. If you want some general study advice, or if you want to download a free study planner, please visit our blog at www.firstaidteam.com. And if you want to work with us at RX Coach, we hope to one day have one of your testimonials on the screen, and we have one here for you. Amazing tutor who goes above and beyond in helping me in this journey to achieve a good score. I've learned so much from our sessions, and I am very grateful for all of his guidance. That's a student from UT Long School of Medicine. So once again, if you're interested in RX Coach and learning more about it and how it can help you maximize your score, like we have for so many students, please visit us online and schedule a free consultation at www.rx-coach.com. Excellent. And with that, let's move on now to question 3. Once again, the answer choices are covered up, and we will begin by reading the lead-in together. What other symptom does this patient most likely have on presentation? And now I'll read this down. An 18-year-old woman who is a college freshman comes for evaluation because of her progressive hearing loss and tinnitus. She has had increasing difficulty hearing her professors in class during the past few months. She undergoes an MRI of the head, which is shown in the image. I'll give you guys a second to take a look at that image. And after that, we will read again that lead-in. What other symptom does this patient most likely have on presentation? Dr. Vicaria.
Thank you, Sean. Once again, we will start at the bottom and work our way up. Answer choice E, pigmented nodules of the iris. D, nevus flammis. C, galactorrhea. B, blurry or cloudy vision. And A, abnormal Rene test. We'll give everyone a second to gather their thoughts. And then, yep, Sean, you went ahead and opened up that poll. Go ahead, Sean.
Excellent. Sorry about that. I think there's a slight delay, Dr. Vicaria. That's what's causing me to jump in a little too soon. I'm not trying to cut you off, and I apologize to all of our attendees. I'm in the middle here of a storm, so maybe that's affecting my internet a little bit. But I'll give you guys a second to select the correct answer or select an answer, and then we'll go over the answer choice again together. Then we'll do one more question, and then 2 lucky winners will win our raffle, and we'll give away some stuff to them. And then we'll have a very special offer for you guys. So make sure you stay until the very end because you must be present to win. At the end, we'll also review some questions. I see some people are asking questions in our question box. If there's any thematic questions, we'll go over those together that all of you guys can benefit from the responses. So we'll give you a couple more seconds. I see that we're having a little bit of a split here with our answer choices, which is good. That means we'll all learn together. Give you guys a couple more seconds and we'll go over the responses. Excellent. Looks like about 2/3 of you guys have answered. So let's take a look and see what we came up with. Looks like 39% of you guys picked A, abnormal Rene test, and then tied for second place with 24% each was B, blurry or cloudy vision, and E, pigmented nodules of the iris. So a challenging question indeed, but one that we hope you will get right on test day because you attended our question lab today. So let's see what the correct answer is. The correct answer is B, blurry or cloudy vision. It looks like 24% of you guys got that question correct. And with that, I will turn it back over to Dr. Viccaria.
Thank you, Sean. So this patient presents with progressive hearing loss and tinnitus, and an MRI of the head reveals something abnormal. We'll show you in just a second, but she had a couple specific abnormalities on her brain MRI that showed two tumors at the cerebellopontine angle, one there and one there. So given her symptoms of progressive hearing loss and tinnitus, as well as these tumors, indicates that she likely has bilateral vestibular schwannomas, as Sean had just pulled up. Now, bilateral vestibular schwannomas are pretty characteristic of neurofibromatosis type 2, or NF2. Now, there are some other high-yield manifestations of NF2. Go ahead and open up that question box again. Post in there some other manifestations you may know of NF2. Now, this may be a little bit more trickier than NF1, but go ahead and give it a shot.
All right, looks like we're getting some responses, and a lot of you guys are saying NF2. Juvenile cataracts, variable activity, another one with cataracts. So, Dr. Viccaria, we got a couple of responses. Tubular sclerosis. I'll let you take it from here.
Thank you, Sean. Yep. So there are some other manifestations of NF2. These can include meningiomas, ependymomas, and cataracts as well. Patients with NF2 are at a heightened risk for developing cataracts and other benign eye tumors. As a result, they potentially could present with blurry or cloudy vision, which is why answer choice B is a correct answer in this question. Now let's talk about why the other answer choices are incorrect, especially since we had a couple other highly selected answer choices. Answer choice E, pigmented nodules of the iris. This is referring specifically to Lish nodules, and these are associated with neurofibromatosis type 1, or NF1, not NF2. Also, this patient doesn't present with other common signs of NF1, such as neurofibromas, cafe au lait spots, axillary freckling. Nothing in that question stem about that, so it is likely not NF1 or answer choice E. Answer choice D, nevus flammis. This is also referring to a port wine stain, which is associated with Sturge-Weber syndrome. And you can have various manifestations with this, and they're associated with specific tumors, leptomeningeal angiomas, and pheochromocytomas. They can also present with seizures, glaucoma, intellectual disability. Nothing here in this question stem is telling us anything about those, so this is likely incorrect as well. Answer choice C, galactorrhea. This is referring to a milky discharge from the nipples, usually as a result of primarily tumors of the pituitary gland, such as a prolactinoma. The patient's symptoms and imaging do not suggest a pituitary neoplasm. The brain MRI is specifically referring to two lesions at the cerebellopontine angle. So thus, this is also an incorrect answer. B, blurry or cloudy vision. We talked about how that's a correct answer. And now let's talk about A, which was also highly selected. Now keep in mind, the Rene tests assesses conductive hearing. This patient is presenting with bilateral vestibular schwannomas, which is sensory neural hearing loss. And that's secondary to a tumor of the 8th cranial nerve. So thus, the results of her Rene test would not be abnormal because that's assessing conductive hearing loss, different than what's going on here, which is sensory neural hearing loss. So the takeaway point from this question is that, a lot of times we remember certain phrases bilateral schwannomas, Lisch nodules, etc. And we associate them with certain diseases. But we often don't even realize that, we don't even necessarily know what they look like sometimes. The USMLE isn't going to just tell you that this patient has a Lisch nodule or that they have a bilateral schwannoma or a lens dislocation. They're going to give you an image, and then you're going to have to visually recognize what that picture is. So keep that in mind. Always make sure you're familiar with what it looks like clinically on imaging, etc. And that'll help you do well on step one.
Excellent. Well, that was a challenging question, and I'm glad that we were able to review it together. If you guys are having issues or having trouble answering these questions or just not able to wrap your head around it, we're here to help. We have wonderful resources, RX360, RX Bricks, and of course, if you want that one-on-one attention, if you feel like you need a little bit more academic support during these times, you need some more guidance, and you're, just not making the progress you want, visit us at rx-coach.com and schedule that free consultation so that we can talk to you and about how we can help you maximize your potential on test day. So now we're going to move on to our last question. Please keep in mind that after we do this question, we are going to do a raffle, so make sure you stick around until the very end. You must be present to win. We're going to give away things to 2 lucky winners, and we have a very special offer for you guys. So with that being said, let's take a look at our last question, and hopefully we can knock this one out of the park. Once again, answer choices are covered up, and we will start by reading the lead-in. Which of the following drugs is most likely responsible for this patient's current symptoms? A 32-year-old man comes to the physician because of a chronic cough and shortness of breath when climbing the stairs. The patient describes the feeling as more of a gasping for air. Personal medical history reveals that the patient underwent a period of chemotherapy for cancer treatment 4 years ago. The patient remembers having severe anemia and bleeding episodes during the treatment 4 years ago. He also recalls that his skin became much darker while taking the medication. Physical examination reveals mild, diffuse, bilateral crackles at the lung bases. The remainder of physical examination is normal. Results of a CT scan are shown. Now let's take a minute to look at that image. Then we will read that lead-in again. Which of the following drugs is most likely responsible for this patient's current symptoms? Dr. Beccaria.
Thank you, Sean. So once again, I'll go ahead and start at the bottom. Answer choice E, vinblastine. D, doxorubicin. C, dactinomycin. B, busulfan. And A, bleomycin. So once again, we'll go ahead and give everyone a second to gather your thoughts. Sean's going to go ahead and open up that poll. Please go ahead and select the answer choice you think is correct, and we'll talk about it in just a second.
Excellent. So our last question of the evening. Looks like we have somewhat of a split with these answer choices again. Once again, keep in mind that we do these question labs weekly. Next week, Tuesday, 6 p.m. Eastern time, we will be covering immunology. And as you guys know, immunology is all over the news right now. So it's a very relevant topic. And we'll be covering immunology Tuesday, same place, same time. So we hope to see you here. All right, looks like a lot of you guys have answered this question. Let's take a look and see how you guys did. Looks like 45% of you guys picked answer choice A, bleomycin, and 29% of you guys picked answer choice B, busulfan. So let's take a look and see what the correct answer is. And the correct answer is B, busulfan. And with that, I will turn it over to Dr. Beccaria.
Thank you, Sean. As Sean has pulled up here, talking about busulfan, one, you can see obviously that it's a chemotherapeutic agent, specifically an alkylating agent. But let's look at those side effects. Severe myelosuppression in almost all cases, pulmonary fibrosis, and hyperpigmentation. Okay, let's keep those in mind as we go back to our question. So this patient is experiencing a chronic cough and dyspnea long after finishing treatment with chemo. The CT scan that they give us shows what looks to be honeycombing. This pattern is consistent or a classic finding of pulmonary fibrosis. Now, we do know that pulmonary fibrosis is associated with bleomycin toxicity, but as we just read, busulfan toxicity actually can cause the same effects. And both can actually cause skin hyperpigmentation. Now remember, this patient told us that he recalls that his skin became much darker while taking the medication. So can you all name what is the key distinguishing factor here in this question? Go ahead and open up that question box again. Post what you think is the key distinguishing factor in this question that makes answer choice B the correct answer.
Wonderful, and questions like this are important because you can narrow things down to two answer choices, and there's that one clue in the STEM, that one clue that can cause you to miss that question. In our coaching program, we want you to know what that clue is, because obviously you guys had a good knowledge base because you guys picked an almost correct answer, but not the correct answer. And those are easy points that we don't want you to miss on test day. So looks like we have some good responses, Dr. Vicaria.
Yep, thank you, Sean. So the main distinguishing factor is that busulfan therapy leads to significant myelosuppression. Now keep in mind that that table that we just saw said in almost all patients, whereas bleomycin does not cause significant myelosuppression. Keep in mind that this patient told us he had severe anemia and bleeding episodes during his treatment 4 years ago. Now, both drugs can actually cause pulmonary fibrosis. There is a little bit of difference in the onset of pulmonary fibrosis. Usually after bleomycin, it occurs maybe weeks to months after treatment, while with busulfan, it usually occurs years after the treatment. So in this case, he's saying that his treatment was 4 years ago. So this is more consistent with pulmonary fibrosis from busulfan. So let's take a look at the other answer choices again and talk about why those are incorrect. Answer choice E, vinblastine. Now, some of the side effects of this include neurotoxicity, such as peripheral neuropathy, and bone marrow suppression. So we talked about how this patient does recall having severe anemia in the past, but vinblastine is not known for causing the current symptoms of skin hyperpigmentation or pulmonary manifestations. Remember that Leadin statement said what is responsible for the patient's current symptoms. So keep that in mind. That's also why answer choice E is incorrect. D, doxorubicin. Now the toxic effects of doxorubicin include cardiotoxicity and myelosuppression. Now with cardiotoxicity, it would usually present as almost like a congestive heart failure or CHF type picture. So they could present with a non-productive cough and exertional dyspnea, and this patient is reporting a chronic cough and shortness of breath. But what we would see is we would see more pulmonary edema on imaging rather than pulmonary fibrosis. And on top of that, doxorubicin doesn't explain the skin hyperpigmentation or pulmonary fibrosis, so also incorrect here. C, dactinomycin. This is an agent that can also cause cardiotoxicity, myelosuppression, and also cause pretty significant nausea and vomiting. Again, this agent does not explain the patient's skin changes and pulmonary findings, just like answer choice D, so also incorrect here. We talked about why B is the correct answer. Let's move on to answer choice A, bleomycin. So this is well known for causing pulmonary fibrosis, as a lot of you selected, and it can also cause skin hyperpigmentation. However, as we talked about, bleomycin usually causes pulmonary side effects in weeks to months after treatment, while in busulfan, it's usually years after. On top of that, it appears that with this patient's most recent chemotherapy, he had significant bone marrow suppression, as we had talked about with his anemia and bleeding episodes. Thus, this is most likely more consistent with busulfan, which causes significant myelosuppression, versus bleomycin, which does not. So a takeaway point from this question is that chemotherapeutic agents and most drugs in general are obviously very high yield for step 1. It's important to know their mechanism and side effect profiles very well, not just the most common side effects, but all of the high yield side effects listed there, and how to differentiate between different drugs and which one is causing an adverse effect.
Excellent. Thank you, Dr. Beccaria. So, we mentioned here pulmonary fibrosis that was caused by a chemotherapeutic agent, but, there's also something called idiopathic pulmonary fibrosis. And if you want to learn more about that, we actually have that in our RX brick resource, which of course we provided to you if you join our coaching program. Let me show you how the bricks work real quick before we do our raffle. So here's a brick on idiopathic pulmonary fibrosis. As you can see, the brick begins with listing learning objectives that we hope that you will learn and take away from the brick. And as you can see here, once you scroll down and you've read that, you have the content review, which what is pulmonary fibrosis? What roles do genetics and environment play in it? We have some images as they come up and are relevant. And we even have here some practice questions via flashcards that you can click to test yourself, clinical correlations when they are necessary. And then at the end, you have a summary of the key takeaway points from this brick. So you go over that summary, hopefully you're able to take all those points away. And then you can practice to make sure you're able to learn what that brick wanted you to learn. You'll answer those questions. And once you do that, you'll be able to review those learning objectives and mark your level of confidence on those objectives from 1 through 5 here, listed 1 through 5. If you want to go deeper, and if you have access to RX 360, you can then open it up in First Aid Facts, open it up in Flash Facts or Express Videos or practice with QMax. And you can see that we even give you an estimate of how much time it would take you to do that in each resource and exactly where it's located in First Aid. So it helps you stay organized and find what you're looking for and practice that specific topic so you can master it completely before moving on to the next one. So that's a quick preview of bricks. If you haven't checked it out, please do so. We even have a free brick available now on COVID. That's available free of charge. So please go ahead and take a look at that so you guys can all learn from it.